Well, it's an honor to be here, and I'm thrilled that we're getting a chance to showcase a little bit of our work. Listening to the first talk really helped me to realize that for many, many reasons, the approach and what Dr. Standiford and I have been looking at really is important. What we're going to talk to you today about is a study that we've completed, and it's the first, we're now into the second study where we're looking at the same tool over a 2-year period. The importance to us on what we produce through whatever method here in the School of Nursing is that our nurses, our students, when they graduate, have to be out there taking care of you. And what we were finding is that as educators, you know, we always struggle with, will they graduate, will they pass? And indeed, we believed, and still like to believe, that about 90% of us think the ones that we graduate are going to be safe caregivers. Startling fact is, when we get out to the hospital side of it, or the clinical side, or the home care side, you're really looking at about 10% believers that we graduate new people ready to practice at a safe level. And we face a lot of additional cost to you as the user of the health care, as well as to the hospitals, in trying to bring those new graduates up to a level that they can consistently provide care at a safe level. We really tried to figure out what we were doing and where's the gap. Well, we realized that this thing called clinical judgment is present, and we really want it to be honed in on, both from the clinical side and from the school side. We were saying this is the key. They have to be able to make clinical judgment. And what we were doing, and what the hospitals in their orientation started to do, is do both the clinical experience and simulations. Because I can't walk in Tuesday morning to a patient on a med-surg ward and say, would you have a heart attack? I've got some students that need to practice taking care of people with heart attacks. It doesn't work that way. So we had to find an environment that does that at that complex, real-time level. And sure enough, we came across the fact that we're looking at simulations one-on-one. Is that a good simulation? Is that a good role play? How did that work? That, not the clinical judgment. So what we wanted to look at was this complex problem and process, and we realized that it is more than just hands-on, do a skill. It has to do with that whole process, and they're taking things in, prioritizing them, making a judgment, managing, doing, and then making the next step, the correction that needs to be, or bringing in other people. Has to be in real time. And when we looked around our school, what was real interesting is we were finding, not just here, but across America, we really didn't have the right types of processes going on at that higher level, nor the tools to measure it. So, in ours, we have 120 hours of clinical practice for every single clinical course. Up to 50% of that can be simulation. There's a lot of factors for that. We don't have enough places for our students to go and have hands-on real experience. We're competing with all these other healthcare disciplines for time with the patients. And as I said earlier, there are situations that we can't replicate in real life. Maybe we're lucky in a whole semester of 15 weeks, there might be a patient who would have a cardiac arrest while we were there, but we can't pre-plan that. So when we looked at the simulation, we really say that we wanted to be able to develop and refine the ability to integrate that data, change the care strategies in real time, make rapid clinical judgments, and that's that higher level of putting it together. And also then implement the action they want, but in a safe way, in a safe environment. And simulation allows us to do that. We even have simulations that are mass casualties and cardiac arrest, and they do kill the patient. We also have ones where they have the patient come out successfully alive. So we're able to give them opportunities not to live the experience, but get a glimpse and to do self-assessment. I'm a firm believer that we all have this blind part of ourselves. And we want that in that 360 world to get as narrow as possible to really know ourselves and understand what we're doing and why. We do totally believe in not just the introduction before the simulation, but the structured debriefing. And the students get to think about their decisions. And we have observers to help them really see what those decisions were. We facilitate their discussion of the prioritization. Why did they choose that? What else could they have done? What would they do different next time? And help them to, on their own, come to that, how can I improve in future situations? The quantification is the issue to us. We really wanted a tool that will help us to identify not just where our students are at, but change over time. If the students come in and they're weak in the area of clinical judgment, and we have all these wonderful experiences for them, over time, are they changing? Are they starting to improve? Are they starting to strengthen? Okay. The tool that we explored, we went through many different ones, but the one that was the soundest one for us is the Jenkins tool. And it actually was from back in 1985, but it's been used many times since then, both in healthcare, medicine, as well as in nursing. 40 items, it measures clinical judgment, and the categories were really important to us. When we looked at it, it was a good match for what we were hearing from the clinical side as well as our own. The individual going through this has to search and explain about alternatives or options. They have to be canvassing the objectives and values. They have to be putting it together. They have to evaluate and re-evaluate consequences, because once you make an evaluation in the real world, it has to be continual, not static, a continual process. And then search for information. How do they search? Where do they search? Are they going out and just Googling and getting that, Wikipedia that a dog can change the definition on? So it was a very simple tool, 40 items. They got a 5-point Likert scale. We really worked hard to make sure that we had our own content validity and reliability. And of course we had permission. The author is no longer available, so the publisher, we had to do some searching. So here's what we wanted to do. What are the demographic variables that influence the development of that clinical judgment? How does that clinical judgment change over time at the senior year? And we found some real interesting things about that. We did descriptive, longitudinal study, and of course we had to go, we're in a university, through IRB. We had, each year we bring in 100 juniors. Of the seniors, we had 89, and it tells you a few of them didn't make it this far. And they were all invited to participate. We built in a little incentive. They got $10 after they completed their survey. Everything came in electronically and was anonymous, non-traceable. We learned a few things around that. And we collected data at 3 points. The start of their senior year, and that's when they start into the higher level complex simulations and courses. And then at the end of that first semester in the fall, and then the end of the spring when they're ready to graduate. As you can see, we had some dropout, 62% down to 37%. But of a good note for us, the ones that did come into the study and stay in the study mirrored pretty nicely our whole class. And so we had, as you would maybe a little surprised, 19 to 47. There's people who do second careers, come into nursing. Majority female, and grade point average, nice and high. And the minority reach in this was about 33%, which we were very pleased with. What we found is that our students actually started out above the national average at their clinical judgment level, which we were very happy with, and we did see change over time. We also identified that the group that was in the bottom 25th quartile in the bottom were the ones that were most at risk. They were not improving over time. In fact, they did some dipping and they stayed either constant or came down. And that's the group that our next study is going to be focusing on. How can we work with this group and do an intervention to strengthen their scores? Of this group, we had 99% pass on, 100% pass on NCLEX, right?
I believe that class was 99%.
99% pass on NCLEX. So we know that our students are graduating, they're becoming licensed. We know that they're coming in that senior year, they're seeing some change. But we really wanted to take a look at, can we identify the ones that are at risk during their junior year and then provide an intervention? And that's what our current study is doing. We're looking to see what intervention we can do. We really feel like instead of looking at individual simulation or an individual role play, that identifying this area, this concept, is going to be advantageous to us, both in helping the students and not just spending a lot of time and money on many simulations, but maybe for that at-risk group, finding a tailored way that we can assist them to improve. And I think what I want to do on the next one is to let you know that we are going forward. And we raised it from the 25th to the 50th percentile just to make sure that we are addressing an at-risk group. Anyone from 50 and lower will be able to have the intervention. We are definitely happy with the tool. We are using it, as I said again. We are now going into the 2-year study, and the presentation will also have the references that we used and our contact information.